Hi everyone, my name is Meredith McCrorie and today I will be presenting my DNP project, a multimodal strategy to activate pronation for acute respiratory distress syndrome patients. This project was created in conjunction with Dr. Stevens, faculty chair, and Ms. Sims, service chief. Acute respiratory distress syndrome, or ARDS, is an acute pulmonary process that compromises the health of patients in the intensive care unit. ARDS can progress to irreversible fibrosis, causing the lungs to become non-compliant, adversely affecting ventilation. This diagnosis accounts for 30 to 40% mortality rate. Annually, nearly 190,000 patients in the United States are diagnosed with ARDS, and this occurs in 23% of patients requiring mechanical ventilation. Manual pronation of ARDS patients has shown an increase in alveolar function with end expiratory lung volume, which leads to improvement in oxygenation and rate of survival. When performing a needs assessment, it was found that ARDS patients account for 10.4% of all ICU admissions. 21,753 individuals in the southern region of the United States died from ARDS, which is nearly doubled from individuals in the Northeast and Midwest regions. The age-adjusted mortality rate for the South is 3.4 per 100,000, with Alabama showing an increased age-adjusted mortality rate of 4.7 per 100,000 patients between 2014 and 2018. From October 2020 to October 2021, there were 457 admissions for both the medical intensive care unit and coronary care unit, with 9.8% of patients having a diagnosis of ARDS that could benefit from pronation. Many were transferred to other facilities during that time to receive pronation services. The purpose of this project is implementation of a validated pronation protocol to offer evidence-based intervention for ARDS patients. This in turn, increasing pronation for patients diagnosed with ARDS. The learning objectives or outcomes for this presentation is to identify the criteria for ARDS patients who require pronation, discuss the outcomes of standardized pronation protocol, and explain the steps of the process. The project aimed to increase the lack of proning by adopting a protocol which highlights criteria and process. Our PICO question that I attempted to answer: in patients with ARDS on mechanical ventilation, does the implementation of a standardized pronation protocol compared to a lack of a standardized pronation protocol increase the rate of pronation? The theoretical framework for this project is Havelock's stages of plan change theory. Havelock's work was greatly influenced by Kirk Lewin's work. He is considered a pioneer to the study of group dynamics and organizational developments. Plan change theory is driven by the idea of factors or forces that influence or impact the situation. These forces can be either driving, which are helping, or restraining, which is hindering. Lewin proposed that an individual who could determine the impact of their forces, both driving and restraining, would have the ability to understand how the entities act and adapt to utilize these forces to change accordingly. Havelock's stages of plan change theory was utilized for this pronation project since it clearly outlines strategic steps for implementation of a process change. In preparation of this project development, there was a need for the process change related to ARDS patients with the lack of pronation occurring within this population. To foster this change, collaboration with stakeholders was conducted to support the protocol. The collaboration aided in fostering relationships with these stakeholders and to support the integration of the protocol. To achieve this goal, I had to acquire the most up-to-date literature and best practices for the protocol development. Once the standard operating procedure or SOP was finalized, identifying the appropriate mechanism for educating the staff of both MICU and CCU was needed. This dissemination, or the extend step, was achieved through intentional staff engagement in the form of educational offerings and simulation experiences. Integrated intentional opportunities for staff feedback within real-time training to address any concerns regarding the SOP and/or education. Following implementation, collaboration occurred with the unit educator to develop the sustainment or renew of educational opportunities with new and existing staff. Prior to the implementation of this project, there was an extensive literature review. Since 1976, pronation has been used to treat patients with ARDS. Pronation as the primary intervention for ARDS patients is not universally accepted, as researchers have found varying results. But over the last 50 years, there have been numerous studies to include systematic reviews, meta-analysis, and clinical trials that explore how prone positioning impacts this patient population. One of the more dynamic studies by Muncie et al., evaluating the existing literature published from a 2010 systematic review and updated the findings with literature roughly through 2016 to evaluate the impact of pronation on a 28-day mortality versus those patients treated with conventional mechanical ventilation in a supinated position. Authors identified 8 randomized controlled trials across a 12-year span that indicated no mortality difference. However, a priori subgroup analysis showed a decrease in mortality when that pronation period was 12 hours or longer per day for studies with moderate to severe ARDS. The takeaway from this study is the greatest benefit for ARDS patients is longer pronation. In Elpern et al., a more recent study that was published in 2021, the researchers confirmed previous findings as they evaluated prone positioning with ARDS patients and COVID-19. These authors theorized that extending pronation periods beyond the 12 hours may be needed to further support positive patient outcomes. They suggested extending it to 16 hours and returning the patients to a supine positioning for 4. Caloris et al. Further confirms the current evidence that supports prone positioning as beneficial for ARDS patients due to improved gas exchange, redistribution of pulmonary pressure, and protection to the lungs. Both observational and randomized controlled trials, according to Benson and Albert, have shown that oxygenation improves in 66 to 75% of patients with ARDS who return from supine to prone. Benson and Albert note there's no evidence that indicates supinated positioning for humans is unnatural, since patients who are supinated experience additional strain on the lungs. Additionally, the Perceiva trial found a reduction in mortality rate at the 28-day mark when patients were prone versus supinated, thus supporting this proposed practice change. Pronation within the ICU setting is relatively safe and inexpensive. However, this technique requires teamwork among the staff to manage unforeseen complications. For example, extubations. According to Olivier et al., the addition of protocols and guides can help alleviate this risk. For the pronation process to become integrated into the daily routine of the staff, a multimodal approach, including dissemination of various educational materials and tools, should be implemented. Giovanni et al. Noted that various studies that describe numerous tools, including protocols, guides, and/or bundles, should be used to implement best practice techniques in an ICU setting. An additional tool utilized to prepare staff is simulation. The use of simulation has steadily grown and has numerous benefits, such as greater acquisition and retention of knowledge and collaboration among the staff when compared to traditional training approaches. This gives the nursing staff the opportunity to identify errors in the pronation process that may result in unforeseen outcomes for the patient. This quality improvement project examined the catalyst use of a multimodal strategy to increase the overall usage of pronation as a non-invasive intervention for ARDS. In 2021, 457 patients were admitted to the medical facility. For that year, and before any intervention was implemented, 4.4% of patients met criteria for pronation, but it was not utilized. Following education to the nursing staff on the protocol, including the standard operating procedure or SOP, checklist, and proning kits, an Excel data collection spreadsheet was developed to track admissions, diagnosis of ARDS, pronation, and any complications related to proning. Project implementation included a standard operating procedure, a pronation checklist, pronation kits, simulation, and data collection spreadsheet. The aim of this project was demonstrated by the increase in the number of patients proned. This study adds to the existing literature that supports the alignment of a multimodal educational offerings targeting healthcare providers and process improvement initiatives. Having a standardized process and protocol allows for increased usage with the healthcare staff, as they can identify patients with or at risk for developing ARDS. They then, in turn, can advocate for pronation with this subset of patients. Having a standardized process and protocol should increase the usage by nursing staff and healthcare providers when providing a targeted intervention. This project supports the theory of targeting specific barriers through protocol initiatives to result in greater success regarding staff knowledge and staff implementation. Prior to the pronation protocol implementation, they were utilizing pronation for only COVIDs. So that left a 55% gap in patients that met criteria but were treated either supinely or potentially transferred out, but not very often during this time period. Post-implementation, we had 100% success rate with patients that met criteria for ARDS and they were proned. In conclusion, ARDS remains a condition with high morbidity, mortality, and high cost to the individual. This project sought to provide standardization through a multimodal approach along with educational opportunities focusing on the standard operating procedure for the pronation process, the evidence-based checklist, and simulation exercises for healthcare staff of both the MICU and CCU. Although the sample size was relatively small due to low census, there is evidence to support that the use of the standardized multimodal approach for pronation. Since the post-implementation sample size was small, continued study to conclude a definitive improvement in pronation intervention for patients meeting criteria is needed. Once the evaluation of the possible benefits of pronating ARDS patients is completed, dissemination of findings was shared with the service chief of the intensive care unit and the associate director of patient care service within the facility. Collaboration with the unit educator occurred to develop an annual competency to ensure education regarding ARDS criteria and the process of pronation is maintained. It will also be included in the initial education for new nursing staff hired for the units. We really want to grow this protocol to our other unit, which is our surgical intensive care unit, to ensure that all critical care staff are competent in recognizing ARDS patients and with the pronation process. And it is our hope to grow this protocol to other hospitals within the region. I would also like to extend a thank you to JSU faculty and staff, especially Dr. Stevens, for his mentoring and support during this process. I would like to thank Ms. Sims for her continued guidance and support also. I would like to dedicate the completion of my DNP project and program to my grandmother. I lost her on January 15th, 2021, related to complications from COVID. Here are my references. And if you have any questions, please let me know.